next few minutes, I'm going to show you how to incorporate endodontics in your implant dentistry practice, discuss the issue of hopeless teeth, and the concept of interim endodontics, list the advantages to you and the patient, and show a few cases. When we say hopeless, I am basically focusing on the idea hopeless in terms of quality of outcome and long-term treatment survival. But for short-term purposes, I have used hopeless teeth to eliminate socket infection, regenerate native bone, reduce the need for traumatic extraction, reduce the need for bone grafts, preserve the alveolar ridge from resorption and collapsing, save the gingival tissue from collapsing, and make buildups for provisional restorations. In endodontics, apical periodontitis is the disease. It's a preventable, progressive bacterial disease, destroys cementum and dentin and bone. The damage to the tooth is irreversible, but the damage to the bone and the socket is reversible with the proper treatment. If treatment is not provided, apical periodontitis gets bigger and more destructive and create lesions. We call them critical size lesions. These lesions are bigger than 10 millimeter that radiographically, bigger than 10 millimeter in width, length, and depth. And this is why CBCT is the best for diagnosis in these situations. With that size, there is a loss of a cortical bone. 50% is gone. Critical size defects do not heal naturally. They need intervention. For us in endodontic, that intervention is endodontic treatment, surgical and non-surgical. In orthopedics and implant dentistry, that intervention is grafting, bone grafting. This is the result in endo. This is continuous evidence-based outcomes. 92 to 97%. We could get this lesion and we could produce this bone without grafting. The quality of this bone is superior. Look at it. This is a lesion with granulation tissue, and we could produce this bone here. I do not put anything in this pocket here because I need to monitor it by radiographs. This is the healing. This bone is native bone. It's denser. You have more volume, and the literature shows it's better for implant dentistry. How did it start? It started back when I was practicing in Southern California, in Pasadena. A referring dentist sent me this patient in the 70s, systemic problem, in pain, and she is on blood thinners. The dentist was planning to replace this tooth with implant. He sent it to me to see what we're doing. All I did was make an access preparation, get into the canal, face calcification, and that's what I did. The patient immediately got better clinically, but then I monitored it for a few months. In 6 months, this is what we got. Tremendous results. With this observation, I applied it on this patient who came to me from New York for the treatment. This patient was a malpractice attorney, did not want to have these two central incisors gone, and basically wants me to save these teeth. This tooth was cracked. I informed him about the interim endodontic, but in the long range, in the long future, once we have good bone, his dentist in New York has to do the implants. And that's what we did. This is basically the retrofill failure. 2 lesions, they became one giant critical size defect. In 6 months, we were able to get this bone regeneration, native bone. Imagine if we had to do surgical extraction and do augmentation. And you know how difficult it is to replace the 2 central incisors in implant dentistry. Another patient, symptomatic, the problem is mesial root. Diagnostic surgery shows a crack. We removed the mesial root, sectioned it, did a curettage, contoured the crown. Here's the defect: no cortical bone on the buccal. The lingual is intact. This is post-operative. 6 months later, 5 months later, we removed the distal root, placed an implant, and the restoration. Another case, beautiful root canal here done by a student. And while she was removing the temporary, she perforated here, unfortunately. What we did is basically hemisection of the palatal root here. This was a huge defect caused to the distal and the lingual palatal bone. We made a provisional on these two buccal roots. She came back. We have a complete regeneration here. Extracted the two roots, put 2 implants, and restored the case. Another case, same situation. Here we do not have a major lesion, but we have a proximity to the sinus. Diagnostic surgery showed me this is an apical third crack. I removed it, burnished the garapercha, waited a year, we placed 2 implants. Thank you for listening.